introduce Dr. Caselli, trauma surgeon, one of the most important and experts in trauma surgery in Brazil. He ran the EMS system in Brasilia, the capital of Brazil, for many times. I visited his hospital, and he before we started to talk about trauma center in Brazil, he will develop the trauma center at his hospital in Brasilia. A very good friend, a very active member of his bite, and for sure going to show us a very nice case and going to lead a great discussion. Thank you very much for presenting, Caselli. Great.
Okay.
Thank you.
Thank you, Dr. Antonio Martos. Good afternoon to everybody. It's a pleasure and a great honor to possible to present this case in this Pan-American Trauma Society. I want to say thank you to all Pan-American Trauma Society, especially for Professor Antonio Martos for the opportunity. Okay. My name is Rodrigo Caselli. I am a trauma surgeon here in Hospital de Base do Distrito Federal. I am a supervisor of the trauma residence program in the same hospital, and also a coordinator in a trauma center in the Hospital Brasilia, that is a private service, a private hospital here in Brasilia. This case in particular, we brought from the Hospital de Base do Distrito Federal. That is a tertiary hospital here in Brasilia, the capital of Brazil, and we covered about an area about with 3 million people of population. It's the biggest hospital in our city, public hospital in our city. We have about 604 beds in the main building. And we have an emergency that's not an open emergency, but a referended emergency, especially in cardiovascular and trauma cases. We have 70 ICU beds, and especially ICU exclusive for trauma with 2 beds, and general and surgical ICUs, coronary ICU, and a pediatric ICU too. We have a surgical center with 16 rooms. 2 of these rooms are exclusive for emergency rooms, special trauma. And we have in this hospital all specialties available 24 hours a day, except gynecology and pediatrics. So all the surgical specialties we have 24 hours a day available. In our emergency department is a big emergency department. We have about 80 or almost 100 beds in the emergency department. And we have all that we need, a blood bank, a laboratory, blood gas analysis, X-ray, and the CT scan near from our ER. That what's good for us. We have a trauma room with 4 beds, this kind of trauma room, and the most of the time is complete with ultrasound, reanimation equipment, adult and pediatric material for all kinds of trauma. Our trauma service, we have in this hospital a dedicated trauma surgeons team, completely separated from the general surgery service. We have 4 trauma surgeons by day and 2 trauma surgeons by night. We have 2 trauma residents, 1 emergency medicine resident, and general surgeon program residents with us in the trauma room. We work with a trauma team with 2 trauma surgeons, 2 trauma general surgery residents, 2 nurses, 2 nurse technicians, and 1 physiotherapist in the emergency room, in our trauma room. This is good for the initial assessment of the patient and guarantee a very quick initial assessment. In terms of statistics, is a good service, is a great service. In 2020, despite the COVID effects of the trauma cases, we have about 10,000 trauma patients in the emergency department, and approximately 700 patients with severe injuries admitted for the trauma service. So we have a good movement in our service, and the most of this case is unfortunately is because interpessoal violence. The pedestrians hit by car and interpersonal violence are the most of our cases. Okay, Well, in this case specific, in our presentation, we talk about initially, this patient comes from the pre-hospital service. We have here in Brazil, the firefighters bring the patient. And in the pre-hospital setting, the information that we have was about the mechanism was a male, 34 years old, was a motorcycle crash about 60 kilometers per hour with stopped bus. And he was wearing helmet the moment of the crash. With the injuries, he has no external bleeding, was sweating, and pain in the right leg and upper abdomen. The vital signs, he has a Glasgow Coma scale of 15. He has a radial pulse present and symmetric. The heart rate was 7/8 and the respiratory rate was 16. And the treatment that they did was an immobilization with cervical collar and spinal board, only this. And the time elapsed from the accident to the arrival of the AD was the 20 minutes. In the emergency room, the primary evaluation according to the ATLS, the patient was conscious, was talking, the airway was patent, and he has pain in the left lower ribs with a murmur decrease to the left hemithorax. The respiratory rate was 18, the saturation of oxygen 88% without oxygen. In the C, he has no external bleeding. The capillary perfusion was normal, but the patient was pale, swollen, and the radial pulses was present and symmetric. And he has painful upper abdomen. No pelvic pain on palpation. The heart rate is still in 7/8. The blood pressure was okay. And unfortunately, the fast was unavailable on that moment. It was in the prevention's maintenance. So we didn't have ultrasound. The Glasgow scale was normal, poops are normal, and there was any findings in the explore the E. So do you have, what's the next step? And I ask to you, this patient, do you indicate the use of tranexamic acid for this patient with these characteristics?
Okay. As I said, folks, you can see we have a lot of participants. So in the interest of time and so everyone can participate, just keep as short as you possibly can, please. Let's go to Ryder. Dr. Boost.
Yes, good afternoon. So the first thing is he has decreased breath sounds on the left side and is hypoxic. So we don't have a fast available, so I would just go ahead and put a chest tube in since he's symptomatic from that, number one. Number two, regarding the tranexamic acid, currently I don't see any evidence of bleeding. He's hemodynamically normal. So at that time, I would not give it unless there's signs that he is hemorrhaging and requires transfusions. Thank you.
Thank you, sir. Mexico, Dr. Perez Benitez, your comments, please.
I agree with Dr. Boost. If fast is unavailable, and right now we have a problem with the B. Let's focus on B and try to get to the abdomen as fast as possible.
Thank you very much, sir. Portland, Dr. Kasim, your comments, please. You're muted, Dr. Kasim.
Right.
Thank you. Yes, sir.
So I'll follow the ATLS protocol. The patient is hypoxic, and you want to find out why he's hypoxic. At least a chest ray should be available if a fast is not available at this moment. So you would get a chest X-ray very quickly in a fabulous hospital like this. That shouldn't be a problem at all. And so get a chest X-ray and then examine the patient to find out why is he hurting in one of his extremities. I didn't get that. I didn't get whether it was right or left. You know, he may have an obvious fracture in one of the long bones in the lower extremity, and find out if that is so, because you can lose considerable amount of blood from that. Now, regarding tranexamic acid, I agree with Dr. Puz, of course. I would not give this patient tranexamic acid at this moment because there's no evidence of any bleeding, that you have not established the criteria for giving TXA to this patient at this moment. And remember, transacectomy has to be given in the first 3 hours following trauma. So keep that in mind, but not at this moment. He doesn't need TXA at this moment. Thank you.
Thank you, Dr. Kasim. Philadelphia, Dr. Alex, your comments, please.
Yes, I agree with the previous comments. Yeah, I would go by the ATLS protocol with the pain and the drop in O2 saturation. I would give him supplemental oxygen. I would do a chest X-ray as Dr. Kasim suggested, and you know, put a chest tube. I would also do a pelvic X-ray to see if he has any pelvic fracture. If there is no FAST and there's concern for bleeding in the belly, then, you know, if you have a pelvic fracture, you need to know about that if you're considering a DPL. Looking at the mechanism, 60 miles an hour straight into a bus, I think this is just a ticking bomb. So we were still in the window with the TXA. I would have it available, but hold off on it as my other colleagues recommended to. Thank you.
Thank you, Dr. Alex. Sao Paulo, Dr. Calais, your comments, sir.
Yes, I agree with all comments, but I think important in this patient, he has injuries on the left side, lower chest, left side, and you have pain in the abdomen. This patient is pale, swollen, above the hemodynamical parameters is normal at this moment. This patient is young, so at this moment, I don't think this patient is not blending. I think he can blending. And in these situations, you can remember that you can have diaphragmatic injuries and maybe herniation. You have spleen, maybe injuries in the spleen, can be the reason sometimes is blending through the chest. So can make injuries, can see. If you don't have ultrasound, you can use X-ray to see what's happening in the chest. The patient may be stable or compensated, and you can, in this situation, start with a venous assessment and put oxygen to the patient. And I believe these patients, at this moment, need if you don't have ultrasound, these patients need to go CT scan, angio CT scan to see what's happened, because he has pain, he has injuries on the lower chest, left chest that you can read, and the machine of injuries is very high energy. So when you think collision with a stop obstruction, you can multiply by 2 the energy was in this patient. So in these patients, I think he needs to go quickly to see what's happened. And I think it's very important to make a CT scan if you don't have ultrasound to evaluate this patient.
Thank you, Dr. Calais. Atlanta, Dr. Frisbee.
Chest X-ray, put your lines in, and I would call the blood bank. I'm really suspicious that this gentleman is bleeding, but he needs a chest X-ray, and I would put his left chest tube in. No text right now. I don't think unless you can establish he's bleeding, it's inappropriate at this point. But I agree. I think he probably needs an examination of that pelvis of his. But at this point, just give him some oxygen, put his chest tube in, get a chest X-ray, and let's see what we've got. No text right now. That's all I have.
Thank you, Dr. Frisbee. Baghdad, Dr. Untrack, your comment, sir.
Yes, I agree with all the other comments. I would probably do a chest X-ray, and pelvis X-ray is fine. Try to include the femurs, the upper legs, to look for likely femur fracture on the right side, and then I would get him to CT scan with the his pulse is 78, blood pressure is holding well, so I would get that done and proceed from there. Thank you.
Thank you, sir. Poughkeepsie, your comments, please. Let's give him a minute to get to the mic.
Hi, I definitely agree. Hi, I'm Dr. Vanatelli from Bassett Brothers in Poughkeepsie. Hard to see, but I agree with all that was said as well, and agree that I think I think I should be very suspicious that this patient has bleeding, but again, using our ATLS protocols, focus on getting a chest X-ray and a pelvic X-ray first, focusing on breathing if he needs a chest tube to get that in first. I agree with alerting the blood bank too and having the TXA available with the high suspicion that this could be bleeding, but being able to get to the CAT scanner as soon as possible while the patient is still stable as well.
Thank you for your comments, ma'am. Back to Sao Paulo to Dr. Garcia.
I agree with the people that just spoke. I think he should go to a chest X-ray, then a pelvic X-ray, then probably a chest tube according to the X-ray. And if he remains stable, like he is apparently stable, I would send them after the chest tube to a CT scan.
Thank you very much. That's everyone showing the video. Not sure if Dr. Stein or Dr. Wellington wants to make a comment. Dr. Stein? Dr. Wellington. Let's go to Dr. Stein and stand by Dr. Wellington Santos. We'll get you next.
I agree with most of what's being said. We've been talking so long. Here we've been done with the CT scan already.
Thank you, sir. Dr. Wellington Santos.
Okay, this patient has a mechanism of trauma that can involve a high energy. Okay, he is pale, he's swollen, and he has a pain in the upper abdomen. And in this case, it's not classic indication of tonexonicasti, but I think that I could give to him because I think he could have a bleeding. Okay, and I put oxygen to this patient, and I think if you don't have the ultrasound, we can send him to make an X-ray if it's possible in the emergency room, a chest and a pelvic X-ray, and if possible we can get a CT. And we won't forget that aortic trauma, because it's kind of a mechanism we always need to remember of this injury. Okay, that's it.
Thank you very much, sir. Any other quick comments or observations before we return to Dr. Caselli? Thank you very much. Dr. Caselli, please proceed.
Okay, let's go. So, the initial management, so we administer oxygen, and when we put the oxygen with mask, with reservoir, the saturation increased to 92%. So we hold the chest tube, no chest tube. Venous access, but no volume, and collected the blood tests. As Dr. Wellington said, we choose to administer the tonexam acid because there was a high energy mechanism involved with the trauma, and the risk of great bleeding. The patient was pale, was swollen, and has a pain in the upper abdomen. So we choose because the risk of the major hemorrhage, and we did the tonexam acid, and was a high energy involved, was a motorcycle at 60 kilometers per hour that crashed with a stopped bus, and it was the high energy involved. We made morphine to analgesia, and we go straight to the CT scan because the CT scan is too close to the emergency. So the time to come the X-ray to do in the emergency room was more easy to go to the CT scan. So we asked the CT scan, we contrast enhanced CT scan of the chest, abdomen, and pelvis. Okay, the results, the head CT scan was normal, no intracranial injury, was fine. On the chest of CT scan, the find was only the fractures of the 60, 80, and 90 left costal arches with no hemo or pneumothorax in the chest, and the parenchyma, the lung parenchyma, was normal. And in the abdominal CT, the find was this, a blurring of a fat in the roof of mesocolon, of transverse mesocolon, this blurring in this area, okay? But there was no signs of bleeding or blushing or bleeding. The radiologist report said only a small amount of free fluid perihepatic, perisplenic, and in the pelvis, and a densification of mesogastric planes related to trauma. This is the findings of CT scan. And when the patient comes back from the CT scan, the abdominal pain was worsening. He's still with the blood pressure normal, but the heart rate becomes more higher, and the saturation was normal, but the patient is still with the skin pallor. We did more analgesia. We start a volume expansion with 500 ml of Ringer. And remember, from the accident from to this moment, the elapsed time was about 2 or 3 hours. So now, what's the conduction? Operative or conservative? It's space for a laparoscopy. What do you think?
Thank you, sir. Dr. Grigsby in Norfolk, I think I missed you last time. My apologies for that. Do you have a comment, sir? Norfolk? Okay, I'll come back to you. Dr. Stein in Tel Aviv?
Yes. I think he earned his laparotomy. We would not have sat on this abdomen if the pain is increasing. You cannot rule out a severe injury. This is a hematoma in the mesentery. The bowel may be compromised. I don't see any parenchymal injury. You didn't mention anything about the liver or the spleen. Is this a fluid, Dr. Caselli?
Question for you, Dr. Caselli. You're muted, sir. You're still muted, Dr. Caselli. I'm sorry, Dr. Caselli.
Because it's showing only two slides.
Okay, the spleen and and there's no injury in the spleen or hepatic injury was normal. The liver was normal and
in that case, the bleeding comes from the mesentery of the bowel, and it's torn, and it's probably there's ischemia of the some parts of the bowel. He needs to be explored. There's also something in the abdominal wall, but I don't have enough cuts here to mention anything about it.
I didn't put the other cuts because everything was normal. The only find was this blurring. Yeah. No blushing or no other lesions.
Yeah, but the abdominal wall is not normal here. And also, you cannot rule out a major injury to the bowel, which needs to be explored,
yes.
my opinion.
Okay.
Thank you very much, Dr. Stein. Dr. Frisbee, your comments, please.
That fatty streaking, that's an indication of bleeding in the mesentery. I wouldn't waste my time. I would open this guy. I think our friend in Tel Aviv is given the right information. He earned his laparotomy. That's exactly what I would do. That's all I got. Thank you, Dr. Frisbee. Let's go to Baghdad, Dr. Untract.
Yes, I agree with Dr. Stein and Dr. Frisbee. This patient, if he just came into the hospital with abdominal, that physical exam and no trauma, that would be an indication for operation. Severe tenderness, and he's tachycardic. On the image on the left, the blurring and streaking, it's extending down to the anterior surface of the pancreas. It's almost like a zone 1 retroperitoneal hematoma. So I agree, he needs to go to the operating room with the provision that there are no fractures and long fractures in the leg that might, into which he might be bleeding, but otherwise the OR. Thank you.
Thank you, Dr. Untract. Poughkeepsie, your comments, please.
I agree with the above. I would definitely take this patient to the OR and perform a laparotomy, as long as there's no other injuries that could be causing the bleeding, but this is sure something that we need to to explore.
Thank you for your comments, ma'am. Dr. Wellington Santos, back in Brasilia. Your comments, please.
I agree with people that's a operative patient. I think he has a bleeding from the mesenterium. Okay, I think is correct to indicate operative now. And I did not indicate laparoscopy because I don't have experience. But if people have experience, I think it's a good option to initiate it, the abordation in this situation.
Thank you, sir. Dr. Garcia, Sao Paulo.
Yeah, usually in cases with free fluid on the CT scan without any solid organ injuries, my option would be to do a laparoscopy. It would depend on the patient, how he's, if he's stable or not, but I would try to talk to the anesthesiologist, see what they think, and probably start through a laparoscopy with a possibility of converting to a laparotomy. But my first option would be a laparoscopy approach for that case.
Thank you very much. Ryder, Dr. Poost, your comments, please.
I agree with what everybody has said already. Definitely needs to be explored. And if you're a skilled laparoscopist and you feel comfortable and the patient is hemodynamically fine, you can do a scope first. Other than that, I would go straight for laparotomy. Personally, I would just do laparotomy on him.
Thank you, Dr. Poost. Mexico, Dr. Perez Benitez.
I agree with Dr. Garcia in Sao Paulo. I would also do a laparoscopy, depending if the whole surgical team has the right training, and if we do have it available, I would start with a laparoscopy thinking and maybe convert them into a laparotomy.
Thank you, sir. Dr. Clay, Sao Paulo, your comments, please.
As I agree, you can start with a laparoscopy in the situation, but with these injuries, I think you have to make exploration, adequate exploration of the colon, the mesocolon, the duodenum, and the pancreas. So sometimes it may be difficult to do it in this moment with the laparoscopy. But I think I can start with laparoscopy and sometimes convert to a laparotomy.
Thank you, Dr. Clay. Philadelphia, Dr. Alex.
Yeah, I agree with all the comments. I think the decision between so first of all, with the radiology, the report sometimes they call back and they say that they see things that now they're not read initially. There's definitely some fluid around the solid organs and in the mesocolon area. I mean, he could be just bleeding in his gut and he's not filling up the belly with blood for whatever pattern of injury. So definitely he needs to be explored. Physiologically, it looks like now he's tachycardic, and so something is going on. If, let's say, his labs look great and his hemoglobin is okay, and especially the base deficit, then maybe I'll start laparoscopically. Otherwise, if I see derangements in his labs, I would just go straight to open exploration. Thank you.
Thank you, Dr. Alex. Dr. Kasim, thank you for your patience, sir. Your comments, please.
Well, Gary, you can, I'm not upset if you call me late, it's okay. So let's look at this case a little bit more. And he's got tachycardia, he's got tenderness, and he's got some evidence of mesenteric injury. He's got some fluid around 3 areas where you usually don't find fluid, i.e. around the liver there's some fluid, around the spleen there's some fluid, and in the pelvis some fluid. So if you add all these together, the patient deserves laparotomy or laparoscopy, as the gentleman from Tel Aviv has informed us right from the beginning. So in my hands, laparotomy works much better than laparoscopy because like Dr. Talat showed us a couple of weeks ago, he had a mesenteric injury, and on the second go around, he opened up the mesenteric injury. Lo and behold, there was a hole in the bowel. So I think I have been burnt once or twice before, but I do know, and I am quite aware, Dr. Coley is a master surgeon in laparoscopy. In his hands, this procedure seems to work very, very well. But in my hand, laparotomy is what I choose because I'm old-fashioned like Dr. Frisbee. Thank you.
Thank you, Dr. Kasim. Any additional comments, observations, or questions before we return to Dr. Caselli? Okay, thank you. Back to you, Dr. Caselli.
Okay, so we option by the laparotomy, the traditional laparotomy. Why do not the laparoscopy? Because the main concern in this case was hemorrhage, was bleeding, was not the contamination or ischemia. The major risk was the blood. This was the main concern, and the time to make laparoscopy, to convert to laparotomy, could be dangerous to the patient. So we go to the laparotomy, the exploratory laparotomy. At the beginning of the surgery, the heart rate becomes more higher, 120 frequency. The blood pressure is still normal, okay? And the patient has on the gas analysis hemoglobin of 9. In this moment, was requested RBC transfusion for this patient. And when you open the abdomen, the finds was moderate to voluminous hemoperitoneum, a deep laceration in transverse mesocolon root with active bleeding, and with under hematoma, expansive retroperitoneal in the right zone 1. And this moment was we did a manual compression of the bleeding. Okay, this was the finds. And was immediately made the cattle brush maneuver, was performed, and find no damage to the inferior vena cava or renal vessels. And in this moment, due to massive pulsatile bleeding, and was suspected of injury of the aorta or arterial branch near this region, and maintain the manual compression with to control the bleeding. So, and now, what's the conduction? What strategy do you suggest?
Philadelphia, Dr. Alex, your comment, sir.
So the bleeding is from where? Zone 1, root of the mesocolon?
Zone 1. There was a hematoma under the mesocolon and was bleeding active from the laceration of the mesocolon.
Okay. I think, so you already did the cattle barrage and the vena cava was normal. I would plan for a supraceliac aortic control, either with a clamp or with just a, sponge stick by the assistant, and then try to approach it as you approach the exposure of the SMA by getting the third portion of the duodenum, ligament detritus, mobilized towards the left, and try to find where's the source of the bleeding. Is it the middle colic coming off the SMA, and just look at the SMA. Was the pancreas? Did the pancreas look okay when you look in the lesser sac, or you did not get to that part? Thank you.
Thank you, Dr. Alex Ryder. Dr. Poost, your comments, please.
Now this case is starting to get interesting. So it's interesting, the question regarding aortic injury, right? So technically you would expect that if you have a CT angiogram of the abdomen, and as you mentioned before, we didn't see all the slides, but you would think that if there was an aortic injury, you should see it on CT scan. But either way, so as Dr. Alex mentioned, we have to get control of this bleeding, and the question is really where it's coming from, right? Is it just a more distal branch of the mesocolic artery or middle colic artery? That should be fairly straightforward to control, or are we dealing with an injury of the SMA, which is much more difficult to control, obviously. So if it's more proximal, close to the aorta, and you can control the bleeding, you may have to get inflow control, as Alex mentioned, by supraciliar clamping of the aorta. Some people also consider an intraoperative balloon catheter in the aorta, rebore. I'm not a big fan. If I'm already in the abdomen, I should be able to just clamp the aorta, so I'm not, starting to get access via the groin and trying to float up the rebore. but some surgeons do that as an alternative as well to get proximal control of inflow. And you just have to figure out now if this is, middle-colic artery or a branch of the mesenteric branches, or is that an SMA injury, or is the bleeding coming from the pancreas, or do we really have an aortic injury here, which would be interesting because if we didn't see it on the CT scan, that would be an interesting case. That's my points.
Thank you, Dr. Booth. Dr. Kasim, Portland, your comments, please.
Well, you have done the Cattell brush already. Now you need to do the Maddox. You move everything from left to right. Then you will have a clear view of the SMA, celiac axis, abdominal aorta, and you will be in the tiger country. So once you are there, you should be able to find out which part of the branches of the aorta there is bleeding. I don't think this is an aortic injury per se, because if it was, he would have been dead by now. Or like Dr. Pooch says, the angiogram should have shown you that there is a rent in the aorta, and you would have had that information long ago. So I think Cattell is on the left-hand side, right-hand side, and the Maddox on the left to medial rotation, and you will have a clear view. And in the meantime, what should you do with the abdominal aorta at the hiatus? I think like Dr. Alex mentioned, the best way to handle that would be a paddle or sponge stick, and a medical student or a nurse or your first assistant. One of those will be valuable at this time. Just tell him to hold pressure there till he's told to let go. And then you should be able to see everything that you want to see and go ahead and fix it. Thank you.
Thank you, Dr. Kasim. Sao Paulo, Dr. Garcia.
The only thing I'd like to add is that if you have started with a laparoscopic approach and you find a retroperitoneal hematoma, zone 1, I think before doing anything else through laparoscopy, the best thing would be to convert the surgery to a laparotomy, and then you can continue the way that the people that spoke before me just said. So I wouldn't do anything through laparoscopy, convert to a laparotomy, and then do the Cattell is done, so Mattox, proximal and distal control, and then explore the hematoma.
Thank you very much. Baghdad, Dr. Untract.
Yes, I agree with, I wouldn't start with a laparoscopy in this case, simply because you wouldn't be able to see very well, if at all, the wound in the lesser sac. So I would move after the Cattell maneuver to exploring the lesser sac, and then at that point you can get good control of the aorta at the hiatus with tamponade. And then if you don't find obviously the area of injury, then by all means the left medial visceral medial rotation would be next. Thank you.
Thank you, sir. Dr. Wellington Santos, Brasilia, your comments, sir.
Okay. I think when you make a Cattell brush, we want to see if it's bleeding is from the cover, and at the time there is no bleeding. And I think the option at the time when it has a bleeding for the zone 1 is to make a supracelic repair in the aorta to stop the bleeding, and after you can attack this bleeding. I think there is less danger for us to have a surprise. Okay, I think this is my conduct in this case.
Thank you very much. Sao Paulo, Dr. Caselli.
Yes, I agree with all comments, but I think you can cross-clamping aorta through hiatus esophageal. You can go to the last sac of the omentum. turn to the left, the esophagus, and then you can compress the aorta through the column and compress the aorta, or can put a clamp. So you can, in this situation, it's much easier than make a Mattox maneuver. So in these situations where is the hematoma, you can see the superior mesenteric artery and superior mesenteric vein can blending or a branch of them. And the aorta, when you see this angio CT, the aorta may be normal. So there is no irregularity in the aorta. If you don't have this, maybe thinking about the branch of the aorta in rupture in this situation. So you can try to control aorta, can do through Mattox maneuver, or can use through the control the aorta through the esophagus hiatus or hiato aortico through in this position. And then you can exploration of the vessels. You can exploration the mesenteric artery and mesenteric vein in this situation can be blending. It's sometimes very difficult to control this hemorrhage in this situation. If have a portal vein injury or mesenteric superior vein injury. So in this position, it's very difficult to treat, but I think it can start with control the aorta, can through the Mattox or through the hiato. That's the way I go to do.
Thank you, Dr. Clay. Dr. Frisbee, Atlanta, your comments, please.
Well, I appreciate all the comments. I think I would never have begun this with a laparoscopy for a couple of reasons. Number one, I'm not very good at it. Number two, you're going to drop the venous return to the heart by 30% with all that pressure in there, and you're obviously going to have to jerk all that equipment out of there and start over. As far as the getting proximal control, you know, I'm from the old school. I would just put a couple of sponges on a stick and lean on it. That should give you enough, you know, pressure to stop the aorta from pulsating, and then I would, you know, do your Mattox maneuver, and you'll have a clear field of just exactly what you're looking at. And that's the way I would proceed with it. That's all I have.
Thank you, Dr. Frisbee. Dr. Stein in Tel Aviv, your comments, please.
Yes, thank you. First of all, for Dr. Caselli, why did you start with a Cattell brush? Was the zone 1 hematoma more to the right? Or was it obviously venous bleeding?
Yes, it was more to the right. Was more to the right.
Yeah, but once you opened it, it squirted like an arterial bleed or a venous bleed. Was it red or dark?
Dark.
Dark. So it was not
dark with rashes of arterial. The mixture.
So you were not sure it was an arterial bleed.
Yes, we're not sure.
That's probably why we didn't see a blush sign on this contrast CT scanner.
Yes.
But if it is an arterial bleeding, then I would agree to go through at least temporarily with the opening of the lesser omentum and controlling the aorta by compression. I would not choose a student or a nurse to press on it. First of all, because you need someone really experienced to press on the aorta in this situation in order to get it effective. At least our students cannot do that. I don't think they can. So I would use someone more experienced, and initially it would probably be me pressing on it because the residents will not be able to do it properly. But then maybe first of all, your hand will interfere with the exploration, and that's when sometimes you can use the Riboa that was mentioned before and inflate a balloon in zone 1. Level 1 and help control the bleeding from the arterial part at least when you start fiddling looking for where it is really bleeding from. If it is an arterial bleeding, then you need to do a Mattox maneuver because that's the best way to reach the roots of all the big vessels that come out of the aorta, not from the right side, but from the left side. So that's what I would have done.
Thank you very much. And our friends in Poughkeepsie, your comments, please.
I definitely agree with everything that was mentioned here. with the Maddox maneuver and super celiac control of the aorta. The other thing too is if we haven't activated the massive transfusion protocol, making sure we have a lot of blood available in the OR. And we're very fortunate here. We have a really great vascular surgery team. So calling for them early in case you need their assistance with this.
Thank you for your comments, ma'am. Let's see, I think the Dr. Perez Benitez, is he still with us? I don't see him. Dr. Benitez. Okay, anyone have any additional comments, observations before we return to Dr. Caselli? Okay, back to you, Dr. Caselli.
Okay, so the patient was, the bleeding was very voluminous, and the supraceliac control was very difficult because the patient was fat, obese, and the surgical camp was a mess. A lot of hands to compress the blood. So the option was for the cross clamping for the aorta through a left anterolateral thoracotomy. This was the option to stop the bleeding, because the bleeding was massive and was completely out of control. So after this control, there was a significant decrease in the bleeding, and the doubt about where is the source of the bleeding, to decide to explore the indirect and the laceration. Once the bleeding was controlled, explore the transverse mesocolon root laceration. And the find was 2 centimeter longitudinal injury in portal vein, just this pancreatic area. And there was a contusion and hematoma, little hematoma and pancreatic contusion, and there was no ductal injury evident on this moment. Okay, and now what's the best option? Ligation or repair the portal vena?
And Mexico, Dr. Hernandez Palma showed up a few minutes ago. Would you like to comment, sir?
No, I'm agree with what you said before. I'm looking for a pancreatic injury, but now I confirm.
Thank you very much for your comments, sir. Poughkeepsie, your comments, please.
Yeah. For the portal vein injury, I would try a primary repair in this instance, help with a lot of our vascular team.
Thank you very much. Atlanta, Dr. Frisbee.
I don't think I want to ligate the portal vein. I think I'm going to try to do a lateral repair of this. That's my comment.
Thank you, Dr. Frisbee. Dr. Untrack in Baghdad, your comment, sir.
Yes, I agree. I would not ligate. It's a young man, and that's really the sole source of bleeding. So I would take my time, get control of that proximally distally, then try to relieve the aortic clamp, and then take your time to repair that properly. The bleeding would be stopped and get that fixed up. But he'll have too many problems down the road with ligation of that vein. Thank you.
Thank you, Dr. Untrack. Portland, Dr. Kasim, your comment, sir.
This the portal vein injury is an important vein for this young man. I agree with Dr. Frisbee and Dr. Untrack. I don't think you should ligate it. So what I have done, I have had a case like this years ago, through the same venorrhaphy, I'm looking at it, I put one of those indwelling shunt in and get controlled proximal distal, and then it gives me time to think about what I'm going to do. The problem with repairing the portal vein without a shunt in place, I have read causes severe stricture of that area, and you may get thrombosis. So I have resorted to put a shunt in there and over the shunt and do a venorrhaphy, and then just before finishing the venorrhaphy, pull the shunt out and close it down, and that's how I would manage it. I think you need patience. No, don't rush this. Thank you.
Thank you, Dr. Kasim. Dr. Stein in Tel Aviv, your comments, sir.
Yes, in this case, in our hospital, we are lucky to be the major transplant center in the country. So in this case, I would probably call our colleagues from vascular surgery and the transplant team to help me deal with this kind of injury. This patient has lost a lot of blood already, I understand, and we don't have the numbers for the blood gases yet. Maybe Dr. Caselli will tell us what's the situation with this patient. If this is in the morning, I don't remember when it happened, what was the time. You will have all the teams in the hospital, and they should come and help because they're more experienced in dealing with this area.
Thank you, Dr. Stein. Dr. Garcia, Sao Paulo, your comments, please.
Yeah, I think that the ligation of the portal vein, I don't think that's an option. I think the question is doing a simple repair or doing some more advanced repair with transplant team or shunt or something like that. But I agree that you need to know how the patient is, because if you had to open his chest to do a cross clamping of the aorta, I don't think he's gonna, you don't have time to wait for anybody to come and help you to do something different, like putting a shunt or something like that. So if he's really bad hemodynamically, and I think he is, because he had that thoracotomy for cross clamping the aorta. So I would do a simple repair, just like a damage control, and just that.
Thank you, Dr. Garcia. Let's go to Ryder, Dr. Poost.
Yeah, I agree with what the other speakers said already. You know, lighting the portal vein has devastating consequences for the patients. You get severe edema of the bowel. You could lose all the intestine if you're unlucky. So all effort should be made to reconstruct the portal vein. And as Dr. Kasim said, the first thing to do is to shunt it, and then really assess and see how bad the injury is. If you can do a lateral venography and you're not narrowing the vein significantly, you're probably okay with just doing a primary repair. But if you narrow the lumen too much, most likely with thrombose, and then you have the same end result with thrombosis of the portal vein. So in that instances, just as Dr. Stein mentioned, it's a good idea, for instance, to get help with the transplant team who deal with this every day. So at our hospital, we're a busy transplant center, we probably would also call help if there's a major portal vein injury in order to reconstruct it properly, for instance, with interposition vein graft using the internal jugular vein or another conduit. The other thing is, you know, you could put the patient on pump, do like a portovenous shunt, like they do sometimes in liver transplantation, and then where you avoid that the intestine swells up, because, you know, as I mentioned before, you know, you put the clamp on that portal vein, very quickly you're going to get a lot of edema of your intestine. So shunting will definitely help with that, or even, you know, putting them on a portovenous bypass on a little pump with help of the transplant team, and then reconstruct the portal vein properly once the patient is stabilized and resuscitated. Thank you.
Thank you, Dr. Poost. Dr. Wellington Santos, Brasilia, your comments, please.
I agree with Dr. Garcia from São Paulo. I think make the ligation of the portal vein is just when you have damage control, okay? And if you can make a repair, I think the best option in this case, always is this.
Thank you very much, sir. Dr. Clay, your comments, please. Thank you for standing by.
Yes, I want to think about where is the injury, because the portal vein comes up of the junction of the splenic vein and the mesenteric superior vein. This may be a supramesenteric vein in the confluence injury. It's not a portal vein. So it's very difficult to think about this. It's in this position, the treatment can try to repair, because if you ligate it, you can be edema of the ball and problems that come on the postoperative. I agree with Dr. Kasim when you can put a shunt, but sometimes shunt in vein is not very good, but you can try to put a shunt. You can remember the patients have aorta clamping, and the aorta clamping is very important. You have not too much time to open the clamp. So the problem is the time we have the aorta clamping. So it's very important in this to repair this patient. So I think if you that have problem, you can put a drain, put a shunt in the mesenteric and portal vein in this situation, wait, and make a damage control to open the aorta clamp. So I think the injury is not in the portal, but is the transition of the mesenteric superior vein through the spleen and the portal. So it's very important in this situation. It's very difficult because we have the pancreas in the middle of these injuries, and we have association pancreatic injury in these situations, and the repair can be very difficult. And the postoperative with with a pancreatitis, traumatic pancreatitis, can be very damaged in these situations. So I think it's very important to think about to measure damage control, to put a shunt if possible, or try to repair the vein. But I think this stenosis may become very, very clear. At this moment, cannot call helping for transplantation in this situation. You can do this, but there is no hepatic injuries, so it can be very difficult to make transplantation indications in this situation. Thank you.
Thank you, Dr. Clay. Dr. Alex, thank you for your patience, sir. Your comments, please.
No problem. I mean, definitely portal vein, repair rather than ligation. Easier, this is the short, but logistically it's more difficult than just the answer, primary repair. A side biting clamp after you put, 2 Rommel tourniquets above and below to get control of it, and see how much that narrows the lumen, and then, repair it with ibuprofen. Definitely, if you get control of that, then you have to keep in mind the aortic clamp that's still on, so you have to try to release that. And also, I agree with my other colleagues who, this is a case where you need more help, either the vascular surgeon or surgical oncologist who operates on the liver more, or transplant surgeons. Here where I'm at would be, fortunate, and transplant surgeons are readily available, and they would come and help. If the side biting clamp would not work, or by placing it in narrows more than 50% the diameter, then I like Dr. Kasim's idea with the shunt, as the transplant surgeon or the vascular surgeon is en route to help. I agree with Dr. Pust to use the IJ as a conduit. It actually has a similar diameter to the portal vein, so that would be the conduit of choice for replacement with fiboproline. That's all I have for now. Thank you.
Thank you, Dr. Alex. I believe everyone had an opportunity to comment. If not, does anyone have a comment before we return to Dr. Caselli? Okay, back to you, Dr. Caselli.
Okay, we have no transplantation team available in the hospital, and we called the vascular team, but we remember that the aorta was clamping. So when the vascular teams arrived, the repair was done, and was tried to make a repair in the portal vein with a continuous suture with Prolene 5 for zeros. And the time elapsed from the beginning of the cross clamping of the aorta was 8 minutes. Okay, after the repair, the aorta was released. When released, the great bleeding of the portal vein was controlled, but there was active minor bleeding to the laceration persists. So was made a complete kosher maneuver and find a laceration of arterial branch behind the pancreas, maybe a posterior superior pancreatic duodenal artery, and was made the ligation. And after this, the bleeding completely stopped. And at this moment, only 2 red blood cells units was made to the patient, and the patient becomes stable of this procedure. And I ask to you, do you think that the use of Reboa was an alternative to aortic cross clamp in this case? And if yes, where is the site of insertion? Where do you use this?
Dr. Calais, Sao Paulo, your comments, please.
Of course, it's an option for you can use the Reboa, but here in Brazil don't have Reboa. You can use Heliante catheter, can use the dilatation to put the aorta prosthesis or other stent. And you can put, I put sometimes here in hospital clinics, I put 2 or 3 times through the femoral artery. I make dissection and put the catheter. The catheter is very high diameter, so sometimes you have problem using for the femoral through use. But here I don't have this the catheter. There is a Reboa, the 7 millimeters, so 7 French, but I don't have the Hyliant catheter. Can be sending a Reboa. You have 12 French, is very bigger and maybe problem. So you can use, but here here in São Paulo, I don't have the catheter to use.
Thank you, Dr. Calais. Poughkeepsie, your comments, please. Sorry to keep making you get up.
No worries. No worries. We don't traditionally use the Reboa catheter here. I guess the zone you would want to try to get into if you could is zone 2, but that's not the easiest to accomplish. If the patient's bleeding badly, I would say just get to zone 1, actually just to control, and then bring that balloon down as you're able to get control over your other areas. But we would have done actually the same control that was described in this case.
Thanks for your comments, man. Philadelphia, Dr. Alex.
I think, considering the resources, of course, thoracotomy and cross on the aorta or zone 1 Reboa would have stopped, the bleeding, and you got to accomplish what you needed. Through a 7 French sheet, an ER Reboa has obviously a smaller diameter and less issues with ischemia to the extremity. So if I were to put one, it would have been in the right groin using ultrasound or cut down to the femoral artery and deploy it in zone 1. Maybe even consider a partial occlusion of the balloon. It's helpful and also decreases the volume of the resuscitation that you would need. And then go from there with the repair. Congratulations for a difficult injury. Thank you.
Thank you, Dr. Alex. Let's go to Dr. Hernandez Palmas in Mexico.
Yeah, well, we don't have a Reboa here, but in case when we can have our service, I prefer to use the Reboa, and side of the introduction is in femoral, but we don't have any experience of use of this. We do the surgery and the control of the artery intraoperative.
Thank you for your comments, sir. Portland, Dr. C.
By and large, people like to put the Reboa through the right femoral. But once you have the abdomen open, and if you're thinking about getting a Reboa in, I have been wondering why would you not open the right common iliac, because you're looking at it and you can get the rumel in 2 areas and make a small arteriotomy and float the Reboa. I've been thinking about it. I've never done it, but then I'm not in favor of doing Reboa in situations like this. I think what the gentleman did is an acceptable maneuver for me, and I like it very much. I think I would stick with what works, and it seemed to have worked very well in this case, and that is the lesson I'll be taking home today. Thank you.
Thank you, Dr. Kasim. Dr. Wellington Santos, Brasilia, your comments, please.
I think Reboa could be used, but like Dr. Calais said, you don't have this catheter in Brazil, okay? But as is, okay, I think the Reboa could be used, but you don't have experience to say about it, okay? That's it.
Thank you, sir. Tel Aviv, Dr. Stein.
Yes, I think we did crack a chest in not a the same case like this, but a massive bleeding in the abdomen when Dr. Caselli was spending some time here with us. But today, it's many, many years later, as I mentioned before, I would control the bleeding manually, temporarily, until we put in a Reboa. And I'm not a proponent of a Reboa, as a matter of fact, but in this case, I've been waiting for this kind of case for a long time, and that's why I have 2 Reboas in the OR waiting for that. I think it's more useful in the OR than in the ER. I still have a Reboa in the ER, but I've never used it. So, actually, I haven't heard of anyone inflating the Reboa in zone 2. I think it's only for zone 1 and zone 3, the indication. Zone 3 is for the pelvic bleeders, and zone 1 is for the abdominal bleeders. So in this case, I think it's much more elegant to do it from the groin. It's probably easier than doing it in the iliac arteries, especially in a fat man like this guy that was just described. It would have been helpful and avoid the morbidity of a thoracotomy, which is, in my opinion, will take even more time to do than putting in a Reboa. Reboa is much easier to put and to inflate. So this is a rare case that I would use an intraoperative Reboa to help us, and then it's much easier to maneuver the exploration when we do the repair of a portal vein like this, which is extremely rare in our experience.
Thank you, Dr. Stein. Let's go to Ryder, Dr. Poos.
Yeah, so as mentioned before, I mean, if I'm already in the abdomen, I usually just clamp the aorta in the abdomen, don't use the Reboa intraoperatively. If you have a hard time to do subdiaphragmatic clamping because the bleeding is right up there, you can't see and you can't feel the aorta, whatever the reason is, you could consider to use the Reboa in that situation rather than doing the thoracotomy. You know, you're not opening another cavity, but it's okay. It's okay to go in the chest and do the clamp the aorta there, whatever it takes to control the bleeding. Definitely, if you have, if the patient arrests, you're going to go to the chest anyway. But, the Reboa is an option to help with the intra-abdominal bleeding. Some of our younger surgeons that like to do it, they use it a lot. I've used it a couple of times. It actually only takes a couple of minutes to float it up. It's not that difficult. So, but you always have to think about, right, if you have a patient who may have an aortic injury, you may not be able to get across with your balloon from the Reboa. So, I mean, this patient, you knew from the CAT scan that most likely the aorta is intact. But some other patients who didn't do a preoperative CT scan, you may not know if the bleeding is actually an aortic injury. And in that case scenario, the Reboa is not going to help you because you're most likely not going to get across the injury. So it's perfectly fine. I prefer to just do intraoperative clamping most of the time, that the old-fashioned way. Thank you.
Thank you, Dr. Poos. Let's go to Dr. Garcia in Sao Paulo.
Don't have anything to add, Gary. Thank you.
All right, thank you, sir. Atlanta, Dr. Frisbee.
Well, if you've got the abdomen open, just go ahead and cross-clamp the aorta. I mean, you're adding a second step, which is probably just sort of redundant. You want to raise the blood pressure of the patient, not your own. And in my hands, that's exactly what would happen. I'm not very familiar with this, and I'm afraid I would raise my blood pressure a lot faster than it is. So if you've got the abdomen open, just go ahead and use either your sponge sticks or cross clamp that aorta. That's all I have.
Thank you, Dr. Frisbee. Dr. Untrack, thank you for your patience, sir. You should have known I wouldn't forget you. Your comments, please.
No, you're welcome, Gary. So I don't have any experience with the Reboa, but my sense was that it probably would take less time to insert this than to do the thoracotomy, so you get control of the aorta quicker with less morbidity from a thoracotomy afterwards. And just a naive question, you already exposed the iliacs and the aorta, and so you have access to those vessels in the abdomen. And isn't it easier, or is there any experience with inserting these through the abdomen, and then you have direct access to repair the arteriotomy when you remove the catheter at the end of the operation? So, but I think it's reasonable to use Reboa in this case.
Thank you, Dr. Untrack. Any additional comments, questions? Everyone have an opportunity to comment before we return to Dr. Caselli? Okay, back to you, Dr. Caselli.
Okay, Just the question about Reboa was because in our service we don't have Reboa, but even if we have it, I think it was not our option in that moment, because remember, at that moment the patient was a massive bleeding, and we don't know where is the source, and there is a compression in the zone 1. The people is compressing with all his strength. How do you will pass through the Reboa without relief this pressure? So I think it's a very, very complicated. I think in this case, the thoracotomy with the cross clamping of the aorta is more comfortable, is a more practical approach. Okay, so the patient was to the ICU and involves okay. The chest tube was removed on 40 days. The patient presents a trachobronchitis and pneumonia because the thoracotomy, but was okay, was treated with antibiotics and was extubated in 80 post-operative day. It was made a serial assessment of Milaz and deputed by the peripancreatic drain that was made through the surgery. And the patient on the 11th day of the internation was admitted to the ward, was discharged from the ICU to the ward. He was normally feeding through the mouth, no fever, no abdominal complaints, laboratory tests was normal, and this was the evolutive, I'm not seeing, the evolutive values of the amylase dosage in the drain. And during the 40th day of the surgery, we made a CT scan for control the drain assessment and the portal vein risk of thrombosis. And was the CT scan made during the 14-day post-operatory. And what we find was just this loculated collection interposed between small bowel on the right flank and cephalic portion of the pancreas, measuring about 130 millimeters, and the drain was not positioned in the right local, and there was no signs of thrombosis of the portal vein. The portal vein was normal through the CT scan, and there was this collection. What we do with this collection?
All right, Dr. Caselli, are you about ready for a final comment, sir? Dr. Caselli?
Yeah?
Yes, sir. Would you like final comments at this time?
Oh, okay. We have to finish. Okay, so we treat the treatment was conservative. We only expected because the patient remains completely asymptomatic, and the patient has a lesion in the right knee, was fixed by orthopedics, and the patient was discharged from the hospital in the 22nd day of internation. The patient is okay. The question was about the anticoagulant, but we have no time to discuss. But because we consider the move limitation with the knee surgery, we decided for rivaroxaban for the patient for 30 days. And the patient comes to the hospital in the last week, and we repeat the CT scan, and the collection is decreased. Until this moment, the decreased volume of collection about 50%, and the patient has no signs of portal vein thrombosis and was completely asymptomatic. Okay, so we think that was an interesting case to discuss, because portal vein injuries are very severe but very uncommon injuries, especially in blunt injuries corresponding to less than 1% of all cases of trauma. The mortality is very high, and literally vary from 50 to 70%, especially when you associate the thoracotomy with these patients, and we have a good outcome case. And the better outcomes are related to precocious diagnosis intervention. We not wait the patient becomes completely hypotensive or completely in high degree of shock. And the strategic procedures to control the bleeding, the control of the cross clamp in the aorta, the ligation versus the repair is a very, very important to the result of the outcomes. And the anticoagulation therapy post-procedure is not, there's no consensus about this, but we choose because the things I already said. So I want to say thanks to Dr. Wellington and Dr. Tamara, was the surgeons that conduct the case, Dr. Renato, our chief of the service, that helped us to make the presentation, and in the name of our trauma team of trauma of Hospital de Base, I want to say thank you for you, thanks for the opportunity, and see you later. Thank you very much.
Thank you, Dr. Caselli. Baghdad, Dr. Untract, your final comments, sir.
Yes, I think very instructive case. So really the teaching point is hematomas to that area in the lesser sac at zone 1 need to be explored. So that hematoma and the symptoms, the signs on physical exam, severe tenderness, and then the tachycardia, and with no other apparent injuries to explain the symptoms, I would explore early and go right into the lesser sac and potentially obtain the control right there. About the repair, when I was the senior resident on the transplant service, and that was 36 years ago now, so I don't know if they're still doing this, but the transplant surgeons were doing a direct portal anastomosis. So the donated liver to the recipient portal vein. And I think as long as you do the repair transversely, that should work, and which is what you did. So a very good outcome, very good case. Thank you.
Thank you, sir. Atlanta, Dr. Frisbee, your final comments, please.
Well, Caselli, you did great. It's a fantastic case. I learned a great deal from your comments. It's really, really nice. You did a great job. Congratulations.
Thank you.
Thank you, Dr. Frisbee. Poughkeepsie, your final comments, please.
Awesome case. That was some amazing work and very quick, so I'm very impressed.
Thank you very much. Let's go to Portland. Dr. Kassim, for your final comments, sir. I'm sorry, Dr. Kassim, you're muted.
Sorry.
Okay, we have you.
Great case. I loved it. And I'm so happy to see gentlemen from Tel Aviv joining us. I wish you would come often. Learned a lot today, Dr. Caselli. Thank you so much.
Thank you, Dr. Kassim. Ryder, Dr. Poos, your final comments, sir.
Yeah, congratulations, Dr. Caselli. Great case, great save. I learned a lot today. It was a really great discussion, I think, for all of us. So thank you so much for sharing your case with us. And I think it's a very good question if we should anticoagulate those patients routinely or not. What means routinely, right? How many portal vein repairs we do in our life? But I was just thinking about, should we anticoagulate those patients, especially in the absence of any other brain injury or liver injury or anything else? So fantastic case. And I think it was a good idea to actually put him on anticoagulation, this patient, especially if there's worrisome that, you have some flow abnormalities, if the vein is a little bit narrowed or something. But very good case. Thank you so much. Thank you.
Thank you. Dr. Hernandez-Palmas, Mexico, your final comments, sir.
Well, thanks for the case. It's a great case, and well, we don't have a very common injuries in portal vein, but well, we have an experience case here, and it was very, very didactic. Thanks.
Thank you, sir. Dr. Garcia, Sao Paulo, your final comments, please.
A great case, Dr. Caselli. Congratulations. Congratulations to you and everybody in Hospital de Base. Thank you very much for the case.
Thank you. Philadelphia, Dr. Alex, your final comments, please.
Thank you for presenting this case. Congratulations to the team for a great presentation, great outcome, and excellent care delivered to that patient. Yeah, but with regards to the anticoagulation, I mean, so he had ortho injury, he was obese. So that was the reason to, I guess, put him on, and that kind of covered the portal vein repair. But let's say if he were to be skinny and no ortho injuries, probably would be safer, as long as, risk benefit, won't, cause problems otherwise. And with that large collection, it looked like there was a window to drain it, I would have probably asked IR to aspirate it because they could, but it was probably less is more, and congratulations again. Thank you.
Thank you, Dr. Alex. Dr. Stein in Tel Aviv, your final comments, please.
Yes, Rodrigo, I would congratulate you for the case. It's an amazing case, an amazing save, and congratulations to you and your team. We don't have that many cases. If I remember, in the last 22 years, maybe we've seen one or two in our center, and I think one of them died on the table. So this is an extremely rare case, and it's a great save you made. Thank you.
Thank you, Dr. Stein. Dr. Wellington Santos, Brasilia, your final comments, please.
Okay. First of all, it's a pleasure to make part of this team from Hospital de Base. I'm going to say thank you, Dr. Renato Lins, is our trauma coordinator, and thank you all of our surgeon teams. And I'm going to say congratulations to Dr. Garcia to have all of these residents to participate in this discussion. I think it's very important for us to touching our residents. Thank you a lot. Okay.
Thank you, sir. Sao Paulo, Dr. Caselli, your final comments, sir.
I have congratulations for the case. It's a very difficult case. It's very difficult to repair this injury. Congratulations for the presentation, to share your case with us. Thank you.
Thank you, sir. Dr. Kasim, did we get your final comments?
Yes, he did.
Okay, very good. Just wanted to make sure not to miss you. Okay, any before I give the last comment in closing to Dr. Martos, does anyone else have anything else? Okay, Dr. Martos.
Yes, Gary, thank you very much. Caselli, another great presentation from your center, from Distrito Federal. Congratulations. To just show that we may not have all the resources available, and that's why we are in this forum. So some places they have everything, and others they don't have. So the idea is to show how we can treat the same patient using the resource they have available in our region or our hospital. This meeting has been going on for 11 years, so that's why I like it so much. We always learn with each other, so that's the main goal of this meeting. I think next Monday, I think Dr. Valerie and Dr. Alon Schwartz from Israel are going to be presenting. And then I'd like to invite you all to schedule Valeria the next presentation. Alex, I think it's your turn again. It's coming for if you have some good case. And please, everybody from Uruguay, Venezuela, Mexico, please talk to Valeria to schedule your case presentation, okay? Thank you very much.
Yes, I have a case.
Perfect. So let's send a message to Valeria.
Comment, Tony, one quick comment.
Yes, Dan, go ahead.
You know, I'm in charge of the membership committee for the Panamerican this year, and I would like to remind everybody who's on right now, we're looking for what we call somebody like a PTS ambassador for each institution. Our goal is basically to have all the main institutions who are actively participating here in this meeting and in the Pan-American Trauma Society to have one contact person for each major hospital who kind of serves as an ambassador to go out and make sure we're recruiting new people into the Pan-American Trauma Society, our medical students, young residents and fellows, and also to remind people that, you know, everybody has to pay their annual membership fees. It's very important for the society so we can continue to exist and have this amazing educational opportunities. So please double check your own membership, make sure you're up to date, make sure you're paying your membership fees, remind your colleagues in your division and your departments, and help us to recruit new members. I just put my email in the chat, so if you're interested in serving at your institution as one of those PTS ambassadors, it would be great if you can email me so we can talk to each other and help that, you know, we recruit more new members and make sure that the members who are already existing in our society continue to participate, be engaged, and also making sure that they're paying their membership fees. Thank you so much.
Thank you, Dan. Again, all these lectures are recorded, so the members have access to these at the Pan-American website, and can be a good tool for education for your residents and fellows later. I'd like to ask Dr. Francisco Collet. Francisco Collet has been in this meeting for 11 years since the first one, and he's the chair of telemedicine for the Pan-American Society to end this meeting. Collet, please. Your final comments and speech.
No, I have congratulations, Antonio, because we're working together about 11 years and make this this meeting very important for the Pan-American Trauma Association and for our knowledge. And you can see people can be increase his knowledge about trauma and how to treat the trauma can be the best and try to do this. So I think it's very important thing in the Pan-American Trauma Association and for all people work with trauma, not only for the Pan-American, but all people work with trauma. Thank you. And I hope this meeting continue for every year, more and more and more. Thank you, Antonio.
Thank you, Francisco. See you all next week.
Thank you.
Take care. Bye-bye.
Take care.
Thank you, guys. Bye-bye.